Balancing the right to habilitation with the right to personal liberties, the rights of people with developmental disabilities to eat too many donuts and take a nap. Article by Bannerman et al. Presentation completed by Susan Hulse. There are 6 ethical principles addressed in this article. According dignity, respecting autonomy, and treating others with care and compassion are the 3 main ethical principles in this article. According dignity is ensuring that each client is treated with respect and dignity, working with our clients on skill acquisition to make sure that they are able to voice or signal their needs and allowing them to exercise their preferences. Respecting autonomy is one of the main focuses of this article is to prompt patients' independence and self-sufficiency. Treating others with caring and compassion is allowing clients to be given choices, devise programs that accord to them in dignity, and treating them with the care and compassion. The next 3 principles addressed are do not harm, benefiting others, and being just. As therapists and caretakers working with and treating people with developmental disabilities, we should consider the benefits of our patients and use our best abilities and judgments when treating and working with them. Do not harm them. Benefiting others is benefiting others in all situations and settings that they may work or participate in activities in. Being just is the last ethical principle to treat others the way that you would want to be treated. The right to habilitation comes down to teaching the skills needed to live as independently as possible. There are 2 cases mentioned in this article, Wyatt versus Stinkley and Youngsburg versus Romeo. Due to many inadequate services for people with developmental disabilities, there have been many class action suits and legislation reforms that have come to protect and provide for the right to habilitation. Wyatt versus Stinkley ruling set minimal standards that include individualized habilitation plans, environmental standards, and assurance of qualified staff and treatment. The Youngsburg versus Romeo Court ruled to ensure that only as much support as needed to ensure the freedom to undo restraint. Since 1976, several other federal and state legislations have taken a stronger position than the courts to secure the right to habilitation. Developmental Disability Act and Bill of Rights Act, the Rehabilitation Act of 1973, Education for All Handicapped Children Act of 1975, just a few mentioned in the article. Nowadays, most laws tie funding contingent upon the client compliance to habilitative standards. In Doe versus Bolton, Supreme Court Justice William O. Douglas discussed that it is the privilege of an individual to plan his own affairs, to shape his own life as he thinks best, do what he pleases, go where he pleases, freedom from bodily restraint or compulsion, freedom to walk, to stroll, or loaf. From the So this begs the question, are service providers allowing clients with developmental disabilities these liberties, and is it in the client's best interest to exercise these liberties? People have the ability to make daily, hourly, even minute-by-minute choices on what they want to eat, wear, participate in, spend time with, etc. And are we allowing people with developmental disabilities the same ability? The ability to make choices about their schedule, wardrobe, meals, learning, etc. This article discusses how some of these personal liabilities can often be compromised in efforts to meet the standards of habilitation, to be cost-effective, and to satisfy parents, caregivers, consumers, etc. There are 4 ways that personal liabilities may be compromised. The first being clients may have little to no input on decision-making regarding treatment goals or treatment procedures. Clients can lack motivation to achieve specific goals or resist teaching procedures. The second way is the lack of regard for the client's preference or past learning experiences that the client may have. Staff may teach leisure activities that they feel would be enjoyable, but it is unknown if something the client is interested in or would want to participate in. Another example is teaching a skill such as brushing teeth. One way, when the client has learned a different way, and yet it's still effective way of brushing their teeth. The third is that the choice making is often not taught to clients. Many people need to be taught how to make choices, determine preferences, and even more so, make responsible choices. To add to this is the lack of professional training to staff on how to teach choice-making skills. Lastly, there are often not opportunities for choice-making available throughout the day. The pressure to meet habilitative standards often causes providers to focus more on quantity and scheduling these activities rather than allowing the client to participate in the choice-making of their schedule. The article then goes into arguments opposing and in favor of choice making. The strongest opposing argument against people with developmental disabilities having the right to make choices is that they can often make bad choices, meaning the choice to nap over participating in other leisure skills or to eat treats rather than fruits and vegetables. The concern is that they may not have the repertoire of skills and understanding of consequences or further implications of their choices and behaviors. The second argument is that allowing them the freedom to choose may interfere with the ability to learn other important living skills that they are needing for everyday routines. For example, learning how to dress themselves. The third opposition is the obligation to achieve the goals that the interdisciplinary planning process team has created. The first argument presented in favor of allowing people who are developmentally delayed to have the ability to make choice is that leisure legislation guarantees the same basic rights as other citizens of the same age and country. In this recent enacted standards for payment for skilled nursing and intermediate care facility services states that staff is required to provide opportunities for the clients to make choices, and the clients have the right to make the choice. Whether it is a small preference or making larger choices with larger implications, all people should be allowed the opportunity to exercise this right. The second argument is in favor of providing choice is allowing clients to make choices in their daily lives. It preps them for the skills that they may need when they are out in the community, working, shopping, participating in community activities, where it is expected behavior for them to make choices and decisions. There are several studies that have focused on to support these personal liberties. All of them indicate that individuals prefer situations where choice is available. Some of the review includes effects of choice on preference, participation, task performance, problem behavior, and response to adverse stimuli. There are some issues addressed with some of these research articles, including using within subject analysis with repeated measurement of the dependent variables and the environment of a clinical setting versus a natural setting, just to name a few. Despite these concerns, the research overall indicates the preference for situations where choice is available and increased participation and reduction of problem behaviors due to the opportunity of choice. The right to make choices and implementing habilitation should not be conflicting goals, but rather work together to enhance client satisfaction and participation, per this article. So how do we then protect the rights of both choice and habilitation? There are 4 ways the article presents to accomplish this task. The first is emphasizing teaching preferred independent living skills and behaviors to the client. This will prepare the client with appropriate and preferred behaviors to make said choices. The second is incorporating input from the client about what skills they will learn and how they will be taught to them. Utilizing preference scales, checklists, interviewing the client, and those close to the client, observing the client can all be ways in determining client preferences. The third recommendation is to teach the client how to make choices and should be part of the curriculum being taught. Going along with this recommendation is to ensure that the staff is well trained on how to teach choice making and how to implement it. The fourth recommendation is providing opportunities to make choice within and about their scheduled activities in both residential and work situations. The implications of this article will be that teaching clients how to exercise their freedoms of responsibility is the key factor to the habilitation process. These should not be 2 separate goals, but rather one cohesive goal to enhance the protection of clients' rights and personal liabilities.